with our hematologists, we run a joint thrombosis pulmonary hypertension clinic. So this is really about what we find in that clinic. So I'll quickly go over. So I've interpreted long-term effects of PE for now as being mainly about chronic thromboembolic pulmonary hypertension, if that's okay. And we can talk a little bit around the other aspects of it. So here we go. There we go. Yeah. So do apologize. It just cuts off half my screen, so I can't see half of it when I'm talking for some reason. So we're going to talk about just an example case, which is one I've just made up, just to illustrate the issues that we will have to deal with. A little bit about the pathophysiology, how I would go about the main diagnosis, and then a little bit about chronic thromboembolic pulmonary hypertension, the treatment options, and then a little bit around that. So if you imagine that a gentleman who I've called AB, 56-year-old gentleman, comes into A&E with a very common presentation. I've been breathless for the last 2 weeks on exertion. Last 3 days, I felt much worse. And he came into hospital because he was feeling a little bit lightheaded, or should we say pre-syncopal, on arriving near the in the last day or so. So he came to hospital. And so he would go on and be admitted to hospital on the basis of this, but the team then later discovered, actually, when you inquire a bit further, he's actually been breathless for the best part of 6 months to a year, and he's put it down to just being busy, not being fit, not doing enough exercise, hasn't really thought about it too much until the last few days. And he has the traditional CTPA on admission, and they find bilateral pulmonary emboli. And so today's not, I've not been asked to talk about pulmonary emboli particularly, so I won't go into any of the details of that. He was appropriately anticoagulated, the usual risk assessment, pulmonary embolism severity index to work out, to stratify his relative risk. He was sent home after a few days, and he will have been followed up in the anticoagulation clinic. So far, so good. Typical pulmonary embolism, with the slight caveat of the story of him being more breathless for a little bit longer than expected. And so when he comes to the pulmonary embolism, to the anticoagulation clinic, it's fine for the first few days. He feels a little bit better, but then as time goes on, he doesn't notice any ongoing improvement. And 3 months down the line, he is only marginally better than he expected to be, than he was when he presented, and far off what he expected to be, his baseline, as it were. And so the question is, what's going on? And so he has a repeat CTPA, and this shows that the large central thrombus that was seen has largely dissipated. And so people are left wondering, why on earth is he still breathless? And this is then reviewed by a radiologist. And it transpires that the radiologist says, well, actually, this is not a normal scan. Yes, the large thrombus has gone, but if you look at the edges of the scan, and we'll have a look at examples later, you can see that the perfusion around the periphery of the lungs is nowhere near what it should be. And then he is recommended to go and have a VQ scan, or if it's available in your unit, a VQ SPECT, which kind of combines a CT element with it, gives you a bit more detail. And then we realize that there are still ongoing bilateral, segmental, and subsegmental persistent perfusion defects. So in other words, this gentleman had an acute thrombotic event on top of chronic thromboembolic disease, and that's probably what's been keeping him, making him more breathless over the previous several months. And then the next step is to then work out whether or not this is affecting his heart by doing an echocardiogram, and the workup that we'll go into a little bit about thromboembolic disease in general. So my interest is in the pulmonary hypertension aspect, which I'm going to explain in a little while, but this is, in a nutshell, the increased resistance in your pulmonary vessels causes a high pressure in the pulmonary circulation, which is not meant to be a high pressure system, and that causes strain on the heart, as we'll see. And so if you think about the spectrum of overall pulmonary thrombotic disease, you can have an acute PE, and if it's a genuinely acute PE, we would normally expect it to if it's appropriately and in a timely fashion managed, we'd hope that it would resolve quite quickly with treatment. However, some people have persistent thrombus, and the current thinking, as we'll go over, is that probably these people aren't having just an acute event, and probably there was a recurrent or an old thrombotic process before the immediate presentation, and then you go on to have pulmonary hypertension in some cases, and we'll talk about the diagnosis in a moment. So how often do people develop chronic thromboembolic pulmonary hypertension? We think at the moment that the incidence is apparently quite low, but we think that that's because we're missing it a lot of the time in terms of its presentation. So just like in the example that I've given, we believe that a lot of these cases could potentially be noticed at the front door, but they are being mistaken for acute pulmonary embolic events. And it's only when they don't recover appropriately that people then begin to investigate a bit further and find the chronic thromboembolic disease, or with or without pulmonary hypertension. I'm going to take a tiny break to explain my terminology. The traditional wording of this is chronic thromboembolic disease, or CTED, and chronic thromboembolic pulmonary hypertension, or CTEPH. They've just announced that they're going to try and alter the name into a slightly more complicated version. So I'm going to stick to these original recent wordings for now. So when you look at the literature, of the people who are known to have pulmonary emboli, about 3%, range between 1 and 9% across various studies, seem to develop chronic thromboembolic pulmonary hypertension, CTEPH. And it's not clear that this is just related to how anticoagulation happens alone. And when you look at some of the earlier studies, the PETO study, even if you get appropriate early anticoagulation or even more aggressive reperfusion strategies, that does not necessarily prevent CTEPH occurring. So then that makes you think again that there's a process more than the simple thrombotic process going on. And what are the risk factors that we can see for this? Well, people have been looking at these risk factors for quite a long time. Intuitively, this would be related to a large volume of pulmonary embolism, and to a small extent that's true, but it's not a very good guide, to be honest. It's probably more useful to see to look for people who are getting recurrent pulmonary emboli, people in whom the anticoagulation strategy has either been inappropriate or ineffective for whatever reason. The original studies looked at, the original cohorts showed some 15% of people had some underlying autoimmune or hematological conditions. A lot of the people who present seem to have more comorbidities in general. And specific things include septal defects, infected pacemaker leads, splenectomy, prior VTE, which is, I guess, recurrent embolic processes, people who don't have a type O blood group. And there are very specific predisposing factors. We've heard of protein S and C and factor V Leiden, and to a small extent they are, but more so people who have lupus anticoagulant or antiphospholipid syndrome. And we know that malignancy is certainly a risk factor for recurrent pulmonary embolism and chronic thromboembolic disease. So going back to this case, what's happening probably is that there's an acute pulmonary embolic event at some point in time, which is insufficiently impactful to come to the attention of the medical community. In other words, it's silent. They just put it down to something else, the patients, and no one notices it until they're asked about it months or years down the line, if they remember at all. And what happens, this is a small enough event that there's only a minor impact on their physiology. They feel less fit, a little bit more breathless, and there's an incomplete resolution by the natural processes, and the thrombus organizes. There may be partial recanalization, and there's a laminate, a kind of endothelial exposed thrombus changes and becomes an organized thrombus, which is no longer so vulnerable to anticoagulants or unnatural coagulation cascade pathways. And so then what happens is you end up with a narrowed vascular system, either occluded or narrowed in parts. And then there is an ongoing distal effect because of the shear stress on the small vessels down the line. There's a reactive change in those vessels, which develop some of the features seen in forms of pulmonary hypertension: endothelial thickening, smooth muscle thickening, which cyclically causes further luminal narrowing in the smaller vessels, and you end up with an overall narrowing of the vascular bed and a progressive increase in the resistance of the vascular bed, and that leads to chronic thromboembolic pulmonary hypertension. And this is a very busy slide, only really to explain to you that what we're dealing with is not just the large central pulmonary emboli, as you remember from the case and the repeat CT that had already dissolved. We're talking about not only the small showers of ongoing thromboembolic material in the distal vessels, but also the reactive phenomenon that occurs around that, with a change in the vessels becoming thicker, lumens narrowing, changes in the blood vessels, development of classic pulmonary arterial hypertension type plexiform lesions, and overall a microvasculopathy that develops in addition to just the occlusive thrombus itself. And what does this mean for your circulation? So again, this is a complicated looking diagram, but really I'd want you to concentrate on a couple of things. In the middle is the schematic of the heart, and the blue side is your right hand side of the heart, the right atrium and the right ventricle on top, and that causes that serves the lung, which is a loop on the right. And really what I want you to see is only a couple of things. The mean pressure in this system is meant to be quite low. The blood gently wafts around the lung in a low pressure system with a mean pressure of 14, possibly lower. And what happens as a consequence of all these, the blockages and the reactive systems, is the pre-capillary system before the lung is affected, and the resistance occurs at that level there. Just to compare against the systemic circulation, which is on the left, the mean pressures, as you know, measured from your blood pressure cuffs, 120 over 80, mean pressures of about 90. So it's significantly different in a normal person. Okay, so in this table, I really only want you to take away what's shown in that yellow shaded area. So in a normal person, the mean pressure of a pulmonary system is somewhere between 8 and 20 millimeters of mercury. I've said 40 in the previous slide. And in terms of evidence base for calling pulmonary hypertension and treatment evidence, you have to have pressures that are greater than 25, with a resistance which is greater than 3 Wood units. And the cardiac output, the far number on the right, may be normal initially and will eventually reduce. So the overall pathology, therefore, is that the vascular resistance increases, and this causes a change in the response of the heart, trying to pump the blood through the higher pressure, higher resistance system. It does that by increasing the pressure. It does that by pumping harder. And eventually it doesn't manage to do that successfully, and the right ventricle starts failing, and that leads to the disease and eventually to the death. And this is just a diagram of what happens to the heart. The actual prognosis and eventual symptoms and mortality is all related to the function of how well the right heart copes with all of this. So in a normal person, you have a large cavity left ventricle with a bowing septum, thick-walled left ventricle, and a small, thin-walled right ventricle, which is crescent-shaped. And what happens with the increase in resistance is that the right ventricle initially hypertrophies in order to pump harder, and then eventually dilates and decompensates and starts failing. As a consequence of this, it also squashes the left ventricle, and you get a combination of factors with the right ventricle failing and causing a compensatory dysfunction of the left ventricle, and this leads to an overall heart failure. And how do you then go around diagnosing these people? Well, the minute you suspect it, the first screening tool, apart from your CTPA, is to get an echocardiogram to see what the heart is doing. And of all of these tests, I've highlighted in red the ones that are relevant for CTEPH, which is the CTPA and the VQ scan. Based on these, you would then go on to do a right heart catheter test, which is an angiogram, and I'll show you in the picture. Just feeds a plastic wire through the right atrium and ventricle. I'll show you in a minute. This is just a quick picture of the echo. Not going to go through this in detail other than to show that what you're really looking for is the parameters around the right ventricle and the flow from the right ventricle into the pulmonary arteries. And there are a number of ways that you would calculate whether the pressures are higher and a number of factors you look for. So the CTPA is the modality that you probably first bring this to your attention. And what you'll look for is the absence of central thrombus. Doesn't necessarily mean that you don't have chronic thromboembolic disease, as in our example. You may get thrombotic material which is not centrally based, eccentric around the walls. You may get subpleural densities, and you may find what's called mosaic attenuation, which is a kind of patchy gray quality to the lungs on CT imaging, demonstrating different areas of perfusion. And you may notice collaterals. So this is an example of those. So if you look at the top image, this cross section of the lungs, what you can see is the mosaic attenuation of the lung tissue, areas which are lighter gray, areas which are darker gray, i.e. less well perfused. The main pulmonary artery is massively dilated compared to the aorta sitting next to it. If you look on the right-hand image, you can see that the ventricle is also dilated, just in our diagram we had before. And if you look down at the bottom, it doesn't show very clearly, but you can see there's the white contrast doesn't go well into the pulmonary artery, which stops abruptly there. So that's the pulmonary embolism and the features of a right heart strain on the CT. But we have gone on to do a VQ scan, and that's because the CT doesn't show the peripheral pulmonary emboli so clearly in all cases. And you can see on the left, the VQ scan shows normal lungs perfusion to all parts of the lung, gradually spreading out to the edge of the lung. And you can see on someone with CTEPH, at the edge of the lung, there are these defects where there is no perfusion, typically in a wedge shape. And that's demonstrating peripheral embolic disease. The gold standard test for the imaging aspect is the pulmonary angiography, which you'll do at the same time as a right heart catheter test. And you can see much more clearly areas of occlusion and raw irregularities. This is an example of what you'd see. So you pass a catheter, where's my cursor, into the pulmonary artery system, and you inject some contrast dye and do fluoroscopy, and you can see the arteries filling up. And then you can see the blush as the flow goes out from the arteries into the lung and back. You have to watch also for the venous return. And from that, you can see clearly which areas are occluded. You can look for areas of post-stenotic dilatation, webs, and all the features of thromboembolic disease. And this is just a diagram of how your catheter happens. This is the catheter coming through the right atrium, right ventricle into the pulmonary artery system and taking the measurements. So I just wanted to quickly go over this very complicated looking slide, but it's really about two patients. I just want to describe to you very quickly. Am I running out of time, Emma?
No, we're okay for a few more minutes. Thanks, Bhashkar.
Okay, I won't go through this in detail. I just want you to concentrate on this bottom figure here and the yellow and the red. The yellow represents a young lady, 24 years old, a real lady who's had a 75% occlusion of her pulmonary vasculature, which is shown on these scans here. You can see this pulmonary angiography. Only the right upper lobe has got any perfusion at all. And her resistance has gone up, which is the y-axis, so it's up to this high. And on the red dot is a lady who's 56 years old, who's only had a third of her perfusion on pulmonary angiography. So this is her pulmonary angiogram. You can see both sides are well perfused, but there are patches where they're not perfused. And so, but she's got chronic thromboembolic disease. And because of the small vessel disease, microangiopathy, you can't see, her resistance is much worse, even though on imaging, only a third of her lung is affected. So you can see the difference in the resistance, and that's the difference that you're really trying to treat and understand. I won't go through this. This is our classification system for how we work out patients are more or less at risk based on a number of things that we measure. The key thing from this is from our classification system, looking at different registries around the world, people do significantly better if we raise them from a high risk category to a low risk category, looking at survival over 5 years, goes from 35 up to 85%. That's the key thing to notice. And so how do we then treat these people? For CTEPH, there are really three major modalities of treatment, which we'll quickly go through. One is endarterectomy, which is a surgery where they have to go in this country to Papworth because the expertise has to be concentrated in one place, and they literally stop the heart under cardiopulmonary bypass, and they open the chest wall, make a snip in the pulmonary arteries, and they peel out with forceps the thrombotic the thrombus. It's a painstaking several-hour operation, but it does very well in the right population. And what they get out of this operation is these horrible-looking clots you can see. So this is sitting in they take this all out in one go, left and right, and they usually present this to the patients actually after, saying, do you want to keep it or not? They certainly get a picture. I get sent one with every patient, and this is about 10 to 15 centimeters long, by the way. So this is not a small thing that you're looking at, each of these, and this is what's been clogging up their arteries, even though they may have some perfusion through it. And the key thing here, which I'd really love you to take away, is that in people in who this diagnosis is made and who are operable, in words that the clot can be reached technically, if those people go on to have surgery, their outcome is dramatically improved over the course of 4 years. So this is the Kaplan-Meier curve. If they have surgery, there's nearly a 90% survival after 4 years. If they don't have surgery, those people who could have had surgery, they do dramatically worse. So it's really important we identify these people and offer them this surgery because it is potentially completely curative in a small percentage and certainly helps overall. In those who don't go on to have surgery, there is sometimes, or in people who have residual pulmonary hypertension after surgery, because sometimes it's the case that the clot is a bit further down and we can't physically reach it with forceps. When I say we, there are 4 surgeons in the country at the moment who are allowed to do this. But and so we can sometimes do something that's done around the world now called balloon pulmonary angioplasty, where you pass a wire to those more distal areas and you literally, just like you do in coronary angiography, you just gently dilate up the pulmonary arteries so that there's flow further in those vessels. It's very dramatically successful in those patients. And this is just a demonstration of various parameters that improve when you do this. And I won't go through that in detail now for interest of time. And this is just a little description of how you'd go about this and choose your patients. So it really depends on where you think the occlusion is. For the central thrombus going down to the segmental level, you would try to offer them surgery. And then from the segmental all the way down to the subsegmental level, you would offer balloon pulmonary angiography. And then if those are not achievable because there's distal disease or non-thrombotic distal microvascular disease, which we've already described, you want to give them medical therapy. Medical therapy takes the form of 3 different pathways. Again, for the interest of time, I won't go into this in detail, but the evidence base really only lies with a few drugs. One is sildenafil, which is only in small studies. It's been trialed, but it's the longest used drug, and it's what we use initially if people are too unwell to wait for the surgery. But the people who've had surgery and have residual disease, the evidence base is for the one at the bottom, which is riociguat, and then if necessary, second line, something called macitentan, which is an endothelial receptor antagonist. And patients generally do very well if they're found with these conditions and treated. And so I've kind of gone over this about the clinical evidence of using the different medical therapies. And so a little bit about CTEPH versus CTED. So in both of these sets of patients, you're going to find that they have exertional dyspnea as their main symptom. If they have pulmonary hypertension as well, they may describe presyncopal symptoms or even chest pain. And actually, the degree of dyspnea, the degree of functional deficit will be much worse with pulmonary hypertension, because not only are they having a limit to their blood flow in their lungs, but their heart is beginning to fail as well. And you diagnose them by a specific kind of right heart catheter test. And both of these conditions, you may notice a perfusion defect on VQ and on various types of angiography. And then what I often do is something called cardiopulmonary exercise testing, which demonstrates not only the functional change that you see in these patients, but also it demonstrates a pattern which you can attribute to a reduced pulmonary vascular flow. And then you can ascertain that these people are limited, not just because they're deconditioned, but because their pulmonary flow system is limiting them, even if they don't have pulmonary hypertension. And the reason that that is important is because over the last few years, and very selectively in the UK, Papworth are now treating people who've got thromboembolic disease without pulmonary hypertension if they're sufficiently limited by that particular issue. And that's quite an increasing cohort of people at the moment. We sent 3 last year from our unit. So CTED is probably significantly underestimated. And this is really just to demonstrate that if you do selectively do surgery in people who've got thromboembolic disease without pulmonary hypertension, you don't have the same prognostic benefit because they don't have the same mortality as people with pulmonary hypertension, but they have a significant improvement in function. I had a patient in the last 6 months who was an airline pilot who was unable to work, and he went on to have surgery last year, and he's now joined a running club. He's so happy. He's gone back to work. And so it's really very successful if you choose the right people. So this is all brought to light the need for having input of respiratory or pulmonary hypertension doctors in thrombosis clinics, and we found it to be a really good venture. I think quite a few places do something similar. I tend to see people who are not improving at that 2 or 3 month stage. If they haven't been caught at the front door, that's when we diagnose them, just as we've kind of mentioned through the process that I've kind of gone over. So on my conclusions, so CTEPH is at the moment probably about 5 to 10 per million, but probably that's underestimating the prevalence. And in terms of the history, I think it's really important that you try and pay attention to the length of the history. It may be very relevant, not just the acute presentation. And VQ scanning is probably the single most important modality to highlight the possibility of thromboembolic disease persisting. And the final thing that's really important to mention, that if you do have these patients, it's really vital to identify them, because without being treated, it is potentially life-threatening. And if they are offered surgery, that can be potentially curative. So there's quite a big difference in outcome depending on how we deal with these people. Fine. That's where I was going to leave it, but I'm happy to take any questions.
Thanks very much. That's given us such a useful insight into what happens to some patients after PE. I think when you discharge them from hospital, you just assume they'll have their treatment and hopefully get better. But as we know, for some patients, those symptoms can be ongoing and the impact on their life is huge. Got a couple of questions here. Somebody has asked about the prognosis for this group of patients. And I think you probably in the latter part of your talk actually answered
Gone over that.
Yeah.
I mean, the key thing is if you have chronic thromboembolic disease without pulmonary hypertension, the prognosis isn't recorded as being specifically different, but they are miserable, the patients, and you can improve the quality of life significantly. If they do have pulmonary hypertension, then the 5-year mortality is something of the order of 70%. So, but if you treat them, then it's 90% survive if they can be. So there's quite a big difference.
Yeah. And do you have a preferred anticoagulant in patients with CTEPH?
There isn't any specific evidence to choose one or the other than in specific populations. So I mentioned fairly early on the patients with antiphospholipid syndrome, and they seem to be particularly problematic. They get recurrent thrombotic events. And what you really don't want is people to have surgery and then have further thrombotic events. And those patients tend to be on warfarin with a higher level of INR. And there's emerging data from Papworth that in the people with recurrent pulmonary emboli, they have and who are candidates for surgery, they are not preferring rivaroxaban. That data hasn't been fully published yet. So we tend in those patients to have to avoid rivaroxaban and use apixaban or warfarin.
Okay. Thank you. That's all our questions, actually. Thanks so much for your time today, Bhashkar. That was really, really interesting, really useful.